clear in Louisville that March actually rode in with the winds and definitely is riding out with the winds. So lying on both ends of the deal here. And that brings us to Clay Smith, our Chief of General Internal Medicine, Education, and Palliative, that is going to talk or present our guest speaker, Bridget Hittepole, the doctor's doctor. She's going to teach a lot of us about obesity, complications, complexities that she sees in the outpatient setting, and probably teach us a lot that we don't understand. She does have a hard stop at 9 o'clock, so let's be cognizant about putting questions in the chat session and limiting our babbling at the end. So I'll have to shut my mouth and not babble so much. So Clay, would you please introduce Bridget so we can get this going?
Absolutely. Good morning, everybody. It's my pleasure to introduce Dr. Bridget Hittepole, an assistant professor in our division who will be giving today's talk. Dr. Hittepole is the medical director of our faculty practice in Suite 370 in the Outpatient Care Center. Having worked alongside her now for almost 10 years in that office, I can say that she is an astute clinician who is dedicated to helping patients achieve better health through lifestyle modification. She's been a member of the Obesity Society since 2014, and after having passed her boards in 2020, became a diplomat of the American Board of Obesity Medicine. Her talk today is entitled Obesity, Complications, Complexities, and Care Considerations. With that, I will turn it over to you, Bridget.
Well, thank you guys for having me present this today. I do appreciate the opportunity. A couple of months ago, Dr. Caroline Apovian gave an obesity talk as well. And hopefully what I discuss today is complementary to what she presented. So yeah, let's jump into it. Let's see here. There we go. No commercial disclosures. I may discuss some off-label use of medication. Some things I want to cover today: definitions, scope of obesity in the US and worldwide, causes, pathophysiology, long-term risk and complications, current treatment options, and also future treatment options. So let's start with the patient case. So 52-year-old female, she presents for a follow-up visit. She has a history of osteoarthritis, GERD, migraine headaches, and obesity. Medications include PPI twice a day, an NSAID for arthritis, and also Topiramate for migraine headache prevention. She does not smoke, drink alcohol, or use any illicit substances. Her body mass index is 41, her blood pressure is normal, and her heart rate is normal. Her laboratory studies do show an elevated ALT at 31, and imaging does show fatty liver. Her A1C was 6.1%. She's counseled on diet and physical activity to help her multiple medical problems, and she has started on metformin. She does say regarding diet, she eats a brownie every day. She really has no plans to change that, but she does say she also likes to eat a banana every day. So she has some positive health behaviors. She says her activity is limited because of her knee pain, so she really doesn't get much physical activity. At another follow-up visit, she started on semaglutide for her hyperglycemia and metabolic syndrome. She is agreeable to seeing a nutritionist, although she feels that she does not have time to go to see a nutritionist. So just some things to think about this patient case, because this is a very common thing that we see overall. If she loses weight, what might actually get better? Likely the GERD would get better, her arthritis would get better, and even if she changed her diet, her headaches would likely get better. And if she doesn't lose weight, what might actually she be at risk for? She's only 52, which is not that old, and so some of these conditions could potentially worsen, and she might be at risk for more complications. This is her weight trend over time. So we have data from 2016 where she was about 217 pounds, and little arrow here. And then in her highest weight here was during the COVID pandemic in March of 2021 at 237. And her ALT at that time was 31, and that's when her A1C was 6.1%, and we started her on metformin. She then got a COVID-19 infection. Where'd my cursor go? Oh, there it is. A COVID-19 infection, and she actually lost about 10 pounds. So she lost weight initially when started on metformin, lost weight with COVID-19, but then her weight went back up. And it was at that point that started on semaglutide, and her weight actually went down about almost 30 pounds. But this is you know, kind of outlining where medication can be beneficial. She still eats a brownie every day, though, I will say. So, okay. All right, so definitions and classifications. So the World Health Organization defines obesity as abnormal or excess fat accumulation that may impair health. Classifications, we kind of all know these, but let's just review them. Overweight is a body mass index of 25 to 29.9, and obesity is divided into different classes, with class 3 obesity also called severe obesity with a body mass index of 40 or higher. And we've mostly all seen this chart with the red, yellow, and green, with red being body mass index in the obese range. And this is in some doctors' offices. We don't see it as much anymore. Our electronic health records usually calculates the BMI for us. And, I will say BMI is not a perfect measure for, adiposity, but it is a fairly convenient measure because it really just gives us the height to weight ratio. Some other measurements that we may want to consider utilizing, though, waist circumference. Greater than 35 inches in women is considered a higher health risk, and then greater 40 inches in men is considered a higher health risk. But this does differ with ethnicity, so this is something to be mindful of. This chart is data from the International Diabetes Federation, and it gives definitions for waist circumference for different ethnicities. So more specifically for South Asians, Chinese, Japanese, a lower waist circumference is more favorable. So that's something to be mindful of. So for females, about 31 inches, and for males, about 35 inches. It's not necessarily beneficial to get a waist circumference in someone who already has a body mass index of 30 or greater. But in somebody who is overweight, or even in somebody who has a normal weight, getting a body mass index, a waist circumference actually might be beneficial to see what their, if that is a marker of health for them. So just to kind of keep that in mind. So some trends in obesity and overweight that we've seen, and this is actually a slide or a graph that Dr. Apovian had in her talk, but it's a good slide, so I felt it was appropriate to present again. So from 1960, because we see the dates on the x-axis there at the bottom, from 1960 up to about 2018, and then percentages on the y-axis. So things are mostly flatlined up until about the mid-1970s, and then we see severe obesity trending up, and that's in the red line. And then in green, we see obesity, and so that's pretty much been increasing rather precipitously, I guess I would say. In men and women both, obesity has been increasing, and severe obesity has been increasing, and severe obesity is higher in women. Overall, severe obesity is about 9%, and obesity and rates are about 42% currently. This is a state map representation of adult reported obesity. So this is self-reported data. So top 3 states are at about 39, almost 40%, and Kentucky is about 36%. So this is from 2020. The lowest states would be Colorado, and then also the District of Columbia is about 11%. And then more interesting here, this is an article from the New England Journal from 2019, where the projected prevalence of obesity in 2030, so that's in about 8 years now. But on the left side here, you can see in 2030, the darker colors here is 60% or greater. So they're estimating in Kentucky, the projected prevalence of obesity is going to be about 60%. Overall, US, they consider the estimated prevalence of obesity as about 50%. So clearly this is a problem that is increasing, it's not going away, and it's actually becoming a very significant problem. It already is a significant problem, but it's getting worse. The map on the right side, this is showing severe obesity. They actually define their severe obesity as greater than 35, whereas our clinical definition is greater than 40. But their rates are significant too. Globally, obesity is a problem as well. We have almost 8 billion adults worldwide, so this is a fair amount of adults, and rates currently for adults 18 and older worldwide, and this is data from 2016, is about 13%. and overweight adults is about 39%. But clearly, United States here, we're one of the highest countries, of course, but we have some other people catching up with us as well. So what's going on? What is happening that we are experiencing these increased trends in obesity? So most of us, I think, have heard of this terminology, obesogenic environment. So that basically says that there's a lot that is happening in our world: food consumption, food production, social psychology, individual psychology, physiology, individual activity, physical activity environment. So let's break down a couple of these things here. Perceived danger in physical environment. I've actually heard from patients specifically when I ask them about, walking in their neighborhoods. I've heard more than one person say, I don't like to walk in my neighborhood because of dogs. And even just walkability of neighborhoods, sometimes there's not sidewalks to walk. So, the actual activity environment may not be amenable. The food availability that people may have, sometimes there's not actually quality food and drink. We've heard about food deserts, and, there's not always quality food available for people close by. So that's a true issue. And, market price of food, right now we're actually seeing, rising food prices. And I think this is actually something that's going to get worse in the future as inflation is becoming more of a problem. And even right now, we don't see quality food as available as in like food that's not as good, basically. And it's easier to eat poorly than it is to eat better in general. But there's a lot that goes into the environment that makes eating better food not as easy for some patient populations overall. And so this is something to be mindful of when we're talking to people in general and what they can afford. So our food in general, I think, is different. And I think this slide kind of helps outline that. So you can see the chickens in 1957. This was an adult chicken that was about 900 grams. And, chickens then up to about 4,000 grams for the adult chicken. And this goes down to a couple things. So that's why I wanted to show this. Food manufacturing is increased dramatically. So this goes down to the chicken production itself is much more, but then also the availability of chicken and then our consumption of chicken. So chicken nuggets, chicken fingers, just every type of chicken product out there. It's available, our demand for it is there, but then we're also eating more of it. Overall, our calorie intake has increased than what it was prior. NHANES data from 1971 to 2000 has looked at our calorie intake and our dietary patterns, and our carbohydrate intake was higher for both men and women. And then men took in about 168 calories more, and then women took in about 300 kilocalories more over that period of about 40 years. So our calorie intake is more than it used to be years ago, but that doesn't necessarily explain everything. But certainly this is part of the equation. So some of the pathophysiology involved here. Obesity is a chronic metabolic disorder characterized by excess adiposity. There are monogenic forms of obesity, so specific genetic mutations. Most of these are autosomal recessive. There's at least 11 known. Leptin deficiency is one of the more common, I shouldn't say more common ones, but maybe one that we know of a little bit better. Leptin discovery is actually somewhat of a seminal discovery in obesity research, and that was in 1994. It actually kind of helped us realize that obesity should not be viewed as just a poor lifestyle choice, but actually viewed as a disorder with a biologic basis. So this actually was something that kind of helped it, realize some investigation into obesity. But most of these monogenic forms of obesity start in very early childhood, before the age of 1 year. But most of the kids start to have hyperphagia. But some of these other MCR4 mutation is probably a more common one, and this is usually heterozygous. And there is a treatment for leptin deficiency. Metroleptin is a IV medication that can be used to treat that. But the MCR4 mutation, that's seen in about 2 to 5% of children that have severe obesity. Polygenic mechanisms of obesity. There's been about 300 loci identified in genome studies, but that's probably less than 5% of the individual variations in body mass index and adiposity traits. The strongest association has been at the FTO locus, that's the fat mass and obesity gene locus. And even though that's a fairly robust association, it's a fairly modest increase in actual body weight of about 1 kilogram for inherited risk allele. In patients who do express this gene, they also trend towards obesity in childhood. So this is actually where getting a weight history can be beneficial to find out if someone was a normal weight as a child and then gained weight later in life, say with pregnancy or some other, event in adulthood, then that is less likely to be a genetic trait for obesity. And then overall, there's this energy dysregulation, so an imbalance of orexigenic neuropeptides complicated by psychological and environmental factors. And let's talk a little bit about that. So this is a very complex slide, but I think it's actually very important. So we have our food intake here. So carbohydrate, fat, protein, and you can put alcohol in here as well. So, our choices that we make on a food intake basis, but then we also have our total energy expenditures. So resting energy expenditure, so thermogenic effect of food and physical activity. You could also put something called NEAT in here. That's non-exercise activity thermogenesis. So the balance of these two, calorie in, calorie out, we could say, is affected by everything that happens in between here. So whenever we eat or drink something, we have a gastrointestinal response and then all these hormones involved in here. And there's a whole lot going on here, ghrelin, leptin, oxymontonodulin, GLP1, but all this then gets processed essentially by the brain. And I've kind of marked the arcuate nucleus of the hypothalamus with this yellow circle here because I think this is an important area to recognize. This is essentially where all these roads lead. So all these hormonal, endocrinologic, neurologic influences basically track to this satiety center that we have. But then we also have this, red arrow over here. I've kind of noted a reward system. So the amygdala and nucleus accumbens, this is our pleasure center. So, our, memories of food and, our desire for food or palatability. So, if Homer Simpson sees some donuts and he's just like, oh, donuts. So that's where he's really desiring to eat, something there. Or just, when we see, smell delicious cookies and we have no hunger at that time, but we just smell that and we want that cookie. So that's our reward system triggering into our desire for eating something. But overall, this arcuate nucleus is what really drives our hunger and satiety. And let's actually talk a little bit more about that because I think this really comes down to where some of our body weight regulation happens. So in the arcuate nucleus, we have two populations of neurons. We have the agouti-related peptide here, and then we have the POMC neurons. So the agouti-related peptide neurons, this is what stimulates our food intake. So any stimulation of this, so like ghrelin is our hunger hormone. So ghrelin will stimulate the agouti-related peptide to increase our appetite. Agouti-related peptide neurons are only in the arcuate nucleus of the hypothalamus. This also has neuropeptide Y receptors on it. Neuropeptide Y receptors are elsewhere in the brain as well. POMC, you can see the pro-opiomelanocortin receptors, and then also CART, cocaine, and amphetamine-related transcript. So these get responses from insulin, leptin, cholecystokinin, so things that will help suppress our appetite. But that also has a feedback on the agouti-related peptide to increase our satiety, to help us, say, oh, you're full, you don't want to eat anymore. But some people have called this the yin and yang model of our satiety and hunger. But this is essentially where, our body helps tell us that we're full. When people do lose weight, typically they're, our body is not necessarily inclined to maintain that weight loss. Even though we it's not healthy for us to be at a lower weight. Our body says that that's not really where we want to be. But when we lose weight, leptin typically will decrease with our fat losses. And if you remember, leptin does improve our satiety. So when leptin decreases, we don't feel as satisfied. So that will actually kind of counteract people to maintain that weight loss, if that makes sense. And then ghrelin typically will increase after prolonged energy deficit. So people who have prolonged periods of weight loss, like their ghrelin will actually usually increase. So this physiologic response for people to regain weight after a long period of weight loss is actually real. Like our body wants to go back to where it was when it has lost weight. And if you kind of think back to that patient case, she lost like 10 pounds with COVID, but then she went right back to where she was. A lot of people after prolonged weight loss, they can't maintain that weight loss, especially after like an illness, that kind of thing. The body wants to go back to where it was. So, we kind of talked about some of these adverse health effects of excess weight, but let's talk about that a little bit more specifically. We do know that there are chronic diseases associated with or complicated by obesity. Talking about her patient case, she did have, osteoarthritis. So mechanical stress on the joints leads to osteoarthritis. The increased intra-abdominal pressure, it leads to GERD and Barrett's esophagus and esophageal cancer. This excess adiposity, we have more, let's kind of go through this little sidebar here on the left side. But the excess adiposity, you have increased adipokine synthesis, and then more of the adipose tissue, macrophages and other inflammatory cells, and more inflammatory cytokines present. And that leads to the impaired signaling of insulin, and then higher insulin levels, and then type 2 diabetes, and then more of the downstream effects of heart failure, stroke, and heart disease. And kind of a similar mechanism that leads to, fatty liver disease, cirrhosis. And, these are very common things that we see throughout our patients who have, excess adiposity, is the elevated ALT, like our patient case. So these are very real chronic diseases that we see among our patients. Interestingly, is this activation of the renin, angiotensin aldosterone system, leading to the systemic and pulmonary hypertension. Then even just this mechanical stress causing compression of the kidneys, leading to the higher pressures that we see. And the other thing is obesity and malignancy. And I think this is something that patients could potentially be very responsive to, because I don't think this is common knowledge among the general population of malignancy and risk of obesity or risk of malignancy related to obesity. But there are very common factors involved here. I think we do know breast cancer in postmenopausal women is associated with obesity and overweight, but also, meningioma is esophageal cancer, multiple myeloma, ovarian and uterine cancer in women, colorectal cancer, pancreatic cancer, hepatic cancer. So these are things that I think patients could potentially respond to a little bit better if they were perhaps more aware of this. Some of the causes of this that, or suspect include chronic inflammation, related to causing DNA damage, and then IGF-1 and adipokines circulate at higher levels in obesity, and those can promote development of colorectal, kidney, prostate, and also endometrial cancers. And then we know that adipose tissue has higher levels of estrogen, and that usually leads to increased risk of breast, endometrial, ovarian, some other cancers. And then there's also some possible risk of non-Hodgkin's lymphoma, male breast cancers, and also cancers of the mouth, throat, and larynx, and possibly some aggressive forms of prostate cancer as well. The obesity-related cancers, it's about 650,000 in the United States. Among men, it's about 200,000. In women, it's about 450,000, which if you think about it, there's, more women with obesity and severe obesity than men, so that would make sense. And usually these are more age-associated, so 50 and older in adults. So let me go. So how do we manage weight? So this is the golden question, right? Everything, kind of why everybody's tuned in today. So our old paradigm is pretty much this. Eat less, exercise more. If you create an energy or a calorie deficit, you will lose weight. If you eat about 500 calories less per day than you expend, you will lose about a pound a week. And overall, there is some truth to this. There is truth to it. You have to, in general, eat less than you burn, because you won't lose weight if you take in more. But it's actually a lot more complicated, and perhaps it actually looks like this, but much, much more complicated. So let's go through that. So there's actually a lot to unpack on this slide, so just kind of bear with me on this one. So metabolic compensation as weight decreases. So we adapt to use our energy efficiently. We are efficient creatures. This is kind of what, physiology made us to be. Some of the studies on Biggest Loser competitors illustrate this metabolic adaptation. But in general, as we lose weight, our resting energy expenditure also decreases. Unfortunately, then if someone were to gain weight, their resting energy expenditure does not necessarily increase with them. So that's not necessarily favorable to them. There's also this idea of non-exercise activity thermogenesis, or NEAT, and this contributes to weight loss more for some people than others. So as Americans, we're not very active. Our average steps per day is about 5,000. As a comparison, Amish communities have very low levels of obesity, about 4%. They get about 18,000 steps per day. So the NEAT, or non-exercise activity thermogenesis, contributes to weight loss much more for some people. NEAT is the steps that we just take, going to and from the bathroom. I'm using my hands. This is NEAT. So just anything that we do that's really not structured activity is in here. And so some people are fidgeters, and that fidgeting actually burns more calories. So this is a significant factor for some people and less significant for others who tend to be just active by nature. So microbiome factors. And so this is something I think is actually sort of potentially exploding maybe. But microbiome has been studied for decades to look at its relationship to multiple health conditions, and probably for about 20 years now to body weight. But our gut microbes metabolize lipids and carbohydrates. And this is actually, kind of one of the most important factors for digestion, I would say. But obese subjects tend to have less biodiversity, but the studies are not necessarily really consistent with this. And I'm going to say I'm not a bacteriologist, so I'm going to butcher these words, but the Firmicutes bacteroidetes ratio is altered in patients with obesity. And in general, the studies do indicate that a higher Firmicutes bacteroidetes ratio is associated with obesity. So Firmicutes includes the gram-negative bacteria such as Clostridium enterococcus. Bacteroidetes are gram-negative bacteria such as Prevotella. But the studies that look at that ratio are not necessarily consistent. There may be differences related to age, gender, and other environmental factors that we don't entirely know what that's all about just yet. And so there's also been studies that have looked at the benefit or lack of benefit of adding a probiotic. And the studies are mixed, honestly. The most supportive studies indicate that multi-strain probiotics may provide the most favorable effects for body weight reduction. Changing our dietary patterns can also alter the gut flora. Diets with more fiber and plant-based foods do tend to increase the bifidobacterium and also lactobacillus that are beneficial flora, and that's part of the Firmicutes. And then, just our standard American diet tends to be much lower in fiber and higher in processed foods. So that is something to be aware of that can contribute to this negative balance with the microbiome for a lot of our patients who struggle with their weight. Prescription medications can be a very complicating factor for some patients, and I've got a whole other slide dealing with this, so I'm not going to talk much more about this. And then presence of endocrine disruptors and contaminating the environment for 30 plus years in the bioaccumulation. So PCBs, phenols, PFAs. The home study that is based out of Cincinnati, Northern Kentucky area, that's been following a birth cohort, and they actually found that serum perfluorooctanoic acid concentrations among some of the home study women were at least twice as high as other U.S. pregnant women. And then their children from age of 2 to 8 had twice the levels of obesity or excess adiposity gain. So not obesity, I'm sorry, but excess adiposity gain. And then PFOAs, those are in carpet upholstery. That's been phased out, I think, in the past 10 to 20 years now. But less than 10% of chemicals overall are actually tested for their endocrine impacts. So this could actually be something that is significant for some patients that, we necessarily can't change that per se, except moving forward is trying to eliminate some of these things from our environment. And then chronobiology and meal timing. This is something that could be a factor for patients, say who are working like third shift or, just more significant. But, we used to think that a calorie was a calorie no matter what time of day you truly had it. But that's, not necessarily the case. What 100 calories that you have at 8 in the morning is actually processed differently than 100 calories at 8 at night. So that's just something to be aware of. Our circadian rhythm, our sleep patterns, all that really affects how our body does process calories. So what is effective for long-term weight management? I like this. I wanted to present this study because I think it does show just overall what helps people long-term. So this is the National Weight Control Registry. It's was started over 25 years ago, but it's followed about 10,000 men and women, mostly women, who've lost 30 pounds or more and have lost that weight. But some of their common factors, most of them eat breakfast, most of them self-monitor their weight, most of them change their food intake to lose weight. Most of them have increased their physical activity, and most of them maintain some level of physical activity. So these are things that most patients have to expect to do to lose weight and to maintain some weight loss. So just something to make sure that we do share with people. So diets, this is the golden question, right? About what is the best diet? Is it ketogenic, intermittent fasting, whole food, plant-based? Vegan, low carb, Mediterranean, Weight Watchers. So the most effective diet is the one the patient can stick to. Weight loss and maintenance of weight loss are long-term goals. So the diet has to be one that is long-term and that can be maintained lifelong. The healthiest diets for long-term health and heart disease risk reduction, though, and also cancer prevention, are the Mediterranean and also plant-based diets. So I personally think that those are the diets that we really need to encourage for long-term health risk reduction, because they also do help with weight loss overall. And I think diets that also reduce the risk to carcinogens are important as well. Our diet is one of the modifiable risk factors for disease, just as smoking is. And I think diet is one of the most important yet, overlooked factors associated with health and disease. Some foods that increase cancer risk include red meat, processed meat, excess saturated fat, and alcohol. These increase the risk of colorectal cancer. Alcohol increases the risk of head and neck cancer, esophageal cancer, and also breast cancer in women. We know cardiometabolic disease is increased by high sodium diet, high intake of sugar sweetened beverages, processed meat, high red meat intake. Low fruit and vegetable intake increases cardiometabolic risk, low whole grain intake. So we know that, we can also reduce the cancer risk if we increase the intake of fresh fruits and vegetables, because that increases our antioxidants like polyphenols, carotenoids, and other micronutrients. So I think if we encourage patients to intake things that are beneficial and reduce things that are less favorable, I think that would be overall beneficial for our patient populations. And we do know high fiber diets also reduce the risk of colorectal cancer, stomach cancer, and also breast cancer risk. So I talked a little bit about diet and health risk, but I wanted to highlight a couple studies that look at obesity and health risk and diet specifically. These, I think, somewhat well-known studies that are population-based. So the Adventist health studies. So the first one started in the 1950s looking at Seventh-day Adventists, because they are encouraged to follow vegetarian diets and avoid smoking and alcohol. And they found that overall they have lower cancer risk, lower mortality, and lower cardiovascular risk. And of course, most people are not perfect, so some of them do smoke and drink, and so they do try to control for some of those factors. And of course, some of them will eat red meat. So they do a lot for, have a controlled population with those. And then the EPIC study, this is a European study, about 10 different countries, looking at some similar factors, but they've shown that less meat intake is favorable to lower body weight and or less obesity as well. So we do have population studies that show that plant-based diets or vegetarian diets are actually favorable for lower cancer risk, lower mortality overall, and less cardiovascular risk. So this is just something to definitely be aware of. And physical activity. So physical activity is something that we should encourage. Studies consistently show that 200 to 250 minutes a week of moderate intensity exercise is associated with weight loss, along with some form of dietary restriction. Morning exercise is associated with more weight loss than evening or late day exercise. Any physical activity can be beneficial when starting from zero, though. Exercise does reduce all-cause mortality. And, multiple studies have shown this. So medications that affect body weight. So there's a lot to look at here, and I do want to go through it because I think this is actually really important because these are things that we can potentially move the needle on for some patients. So diabetes, we know insulin and sulfonylureas do contribute to weight gain. So we have a lot more medications for diabetes that we can prescribe that now help with weight loss. So metformin, Glp1 agonists, SGLT2 inhibitors, like these are great medications now that we can prescribe for patients who have diabetes that actually can help with weight loss. For hypertension, beta blockers, unfortunately are not favorable for weight loss for patients, but there are some alternative beta blockers, carvedilol or nebivolol. Are alternatives, if we have to use a beta blocker. For depression, it's a mixed bag. There are some that are, weight promoting and some that can be more for weight loss. Honestly, the only antidepressant that does help with weight loss is bupropion. Bupropion, you have to watch blood pressure with it, and you can't use it in anybody who has a seizure disorder, but it is truly one that can help with weight loss in people who struggle with that and depression. Antipsychotics, if this has to be used in a patient, the only one that has less weight gain associated with it is Ziprasidone. So that's something to be aware of. Anti-epileptics, this is also a bit of a mixed bag. We tend to prescribe gabapentin and pregabalin for neuropathic conditions. Unfortunately, these tend to promote weight gain in patients. And unfortunately, we also prescribe them in patients who already struggle with their weight, patients who have diabetes. So this doesn't really help the condition overall. Consider maybe using a topical medication for neuropathy instead. For epileptics, so you do have some options. And several that actually can be more weight neutral and potentially weight loss. So that is something to keep in mind. Depo-Provera for birth control does promote weight gain. Most oral contraceptives do not. Some women fear that oral contraceptives do cause weight gain though. And then of course we know corticosteroids are weight promoting. NSAIDs typically do not. Interestingly, antihistamines such as loratadine can be weight promoting. Consider maybe a nasal steroid like fluticasone instead. But I think this is important information to be aware of, that patients could potentially, change some of these medications around. If somebody's been on Paxil for years or Paroxetine for years, and maybe a different antidepressant would be warranted if they're struggling with their weight. So anti-obesity medications. So this is something Dr. Apovian went through, but I do want to go through it because I think it is important that we are aware of the medications that we have available. A couple notes on these. Consider using medications for patients who have comorbid conditions with a body mass index of greater than 27 or greater than 30 without any comorbid conditions. I would not necessarily use these in a woman who is pregnant or considering pregnancy in the near future. If a patient's been on a medication for about 12 weeks and hasn't responded, either escalate the dose or consider changing to a different therapy. And I did put information about cost in here because not all insurances are covering these medications, which is super disappointing. So some patients are looking to pay cash. I actually got this message from a pharmacist recently. This patient's Wegovy is not covered. Services related to weight management, anti-obesity, and BMI are not covered under Part D. And this is just really sad that insurances are not covering weight management for patients. But this is where we're at, unfortunately, and we hopefully in the future more of these medications will be covered, but this is where we are. Some insurances will cover these if we do get a prior authorization, but that is more paperwork, unfortunately, but they will cover them. But let's go through these. So phentermine, this is an amphetamine, so it is a stimulant. It is one of the cheaper medications, as you can see, about $20 cash out of pocket at Costco. It was the first one FDA approved in 1959. It does have a side effect of sometimes tachycardia and high blood pressure, so that's to be monitored. Most studies show that you can use this for long term if you need to. And then we have this combination of phentermine topiramate, also marketed as Qsymia. And so cost-wise, it's about $200. I will say that you can order this through the website. I can't think of what the pharmacy is, but there's a mail order pharmacy through the manufacturer's website that you can send it to where the patient can get it for about $100 a month. So it is a little bit more affordable that way. And, you know, these are two medications that actually have been FDA approved for years, but then they just combined it to make this weight loss medication. Side effects, you know, numbness, tingling in the fingers related to the topiramate, and the phentermine, some of the similar side effects with that. You do not want to use topiramate in a woman who is pregnant or plan to become pregnant because of teratogenicity with that medication. So definitely be aware of that. And you don't want to use it in anybody with a history of glaucoma either. Bupropion and naltrexone, this is similar in that it's a medication that, you know, two medications that have previously been FDA approved, and they studied them for weight loss and brought them together to make Contrave. Cost about $200 a month cash out of pocket. Bupropion can cause high blood pressure. That's something to monitor. Naltrexone is an anti-opioid, so a patient, if they're on opioids, you don't want to use naltrexone. If a patient's about to have a surgical procedure, this medication needs to be held as well, so something to be aware of. Orlistat, this is the fat blocker, basically. I typically don't prescribe this one because it has that fat, oily stool as a side effect, and most patients don't like that. But it's actually pretty expensive for the prescription anyway. Over the counter, it's not too expensive, but it is dosed 3 times a day, and most people don't like that. So the Glp1 agonists, these are sort of the newer agents that we have. Liraglutide, that is a daily injection. If a patient were paying cash though, that is really expensive, about $1,400 a month. And then semaglutide, that's a weekly injection. That's the Wegovy. The daily injection of liraglutide, that's Saxenda. But Wegovy is the same ingredient as Ozempic, which is marketed for diabetes. And then I just added this Rybelsus, which is an oral agent for diabetes. So that's the same ingredient that's semaglutide. So just kind of an FYI there. And then metroleptin, I just included this for the heck of it. So that's a synthetic leptin analog. That's about $300,000 a year. So that's prescribed for people who have a leptin deficiency, and people also might have a lipodystrophy syndrome. That's been prescribed for them as well. And then just some of the side effects of the GLP-1 agonist, I do want to include this. So nausea, diarrhea, constipation. You do not want to use it in somebody who has a history of medullary thyroid cancer, a history of pancreatitis, or a history of Men's syndrome. So that is something to be aware of. The GLP-1 agonists have been shown to have about a 10 to 12% reduction in cardiovascular disease, though, and they also are favorable in fatty liver disease. I did see some recent data, and that they have a slightly higher risk of biliary disease, though. So just something to be aware of with these. So some of the mechanisms of these drugs, let's kind of look at this. I like this slide because of where it shows these mechanisms at here, okay? But let's look at the central mechanisms here on the left first, okay? So I've got some big arrows kind of showing here the nucleus accumbens, remember that's the reward center, and then here the arcuate nucleus on the right, that's the satiety center essentially. But you can kind of see where liraglutide, semaglutide, so that's the GLP-1 agonist, has several different areas that it is active in. So I think that's something important to note. that has multiple areas in the brain that is effective in. The other thing I want to say about this slide is where, and let me point to the little brain here in the middle. So you see our third ventricle here. So these medications have to cross the blood-brain barrier to be effective. So there's some fenestrations right here at the blood-brain barrier so they can reach the hypothalamus here a little bit more readily. And semaglutide is actually a smaller molecule than liraglutide. So semaglutide, I think, actually can reach the brain a little bit more readily than the liraglutide. And then peripheral mechanisms here, you can see the GLP-1 receptors on the pancreas, the stomach, the small intestine here. And if we had a little picture of the liver, it'd be on the liver. And if there's a picture on the heart, it'd be on the heart too. And then you can see where the Orlistat works down here. So future medications. So there's an amylin analog called cagrilintide that looks like it's been under study. There's just an article published in the Lancet a couple months ago. They compared that to liraglutide, so a GLP-1 agonist, and it showed fairly significant weight loss, just a couple kilos more than the liraglutide. It had a fair amount of GI side effects compared to placebo, though. Side effects have decreased some GI side effects, basically. Terzepatide. So this is actually at the FDA for approval right now, so pending review. This is actually a dual agent of a GLP-1 agonist and a GIP receptor agonist. So it's actually been developed for type 2 diabetes, but it has a benefit of weight loss with it. And I think the company is debating whether they're going to market it as two separate agents with two separate indications, one for diabetes and one for obesity, kind of how the Wegovy Ozempic is, or just one agent with two separate indications. But they compared this in the studies to dulaglutide versus placebo, and it had the range of dosages was different, but the weight loss was up to about 11 kilograms after about 26 weeks, compared to the medium dose of dulaglutide, which is about 2.7 kilograms. So this slide I actually really like because it compares all these medications to each other. So on our y-axis here, okay, cursor, y-axis here, we have weight loss from the baseline, and then on the x-axis we have the time in months, okay? All the way at the top here, you see diet and exercise, so not super effective. People lose weight initially and then they gain it back. And then all the way at the bottom is bariatric surgery. Okay, so bariatric surgery, very effective in the first 6 months, and then a little bit of weight regain. So I've marked this arrow here. This is the semaglutide at the weight loss dosing. So that's the highest dose for weight loss at 2.4 milligrams. And then I marked this arrow up here for the semaglutide at the diabetes dosing. So there is a difference in the weight loss after with the different dosages of the medication. And then the next one up is the Terzepatide. So that's the one to FDA for review. And then the one right above that is the Phentermine Topiramate combination. So I just thought this slide was a good comparator for those medications that are more effective. And then bariatric surgery is also something to be aware of as an option for patients that would potentially benefit from this. So in 2017, there were 230,000 bariatric surgeries. 18% were Roux-en-Y, 59% were sleeve gastrectomy, and 33% of them were adjustable band surgeries. So, patients that would not be candidates for bariatric surgery would be people who have untreated psychiatric disorder, people with an eating disorder, current drug or alcohol abuse. Not all insurances cover this, so that is something to be aware of, but it should be considered for patients who have a body mass index of greater than 40 or a body mass index greater than 35 with comorbid conditions. And this is still just a tool for weight loss. People can get bariatric surgery and still not be successful with weight loss. So they need to be aware that they still need to do, still need to diet and exercise even with a bariatric surgery. So let's look at bariatric surgery and all-cause mortality. So this is a study that's published in 2020 from the Annals of Internal Medicine. And this looked at a population in Canada of about 13,000 surgical patients compared to non-surgical patients. It was mostly gastric bypass, but it was a retrospective cohort study. And you can see on this graph, mortality is on the y-axis here. And then they started with the years following surgery, so 13,000 patients in each group, and then the years following surgery. And then the solid line is the surgical patients, and then the non-surgical patients in the dashed line. And so they compared their mortality rates. And overall mortality was decreased by about 32% in the surgical patients. And that was driven mostly by cardiovascular risk being reduced and also malignancy risk being reduced. The populations that was most significant for, though, was patients who were 55 and older, though, and also those who had a body mass index greater than 40. So it didn't tend to hold as true for patients who were younger, and then also who had lower body mass indexes. So patients who were 55 and older, and then also BMI of 40 and greater. And then there's also a Swedish obesity study that's followed patients for about 20 plus years, and they had recently published some data that showed lower cancer risk and also remission of diabetes in their bariatric surgery subjects. So we do know that bariatric surgery can be beneficial if we are looking to reduce disease risk in patients who have obesity. So just some take-home points. Obesity is a chronic metabolic disorder. Obesity carries a higher risk of mortality and a higher risk of comorbid conditions, including diabetes, hypertension, heart disease, and malignancy, among many other chronic conditions. Obesity has a complex pathophysiology with complicating variables related to psychology and food environment. Diet and nutrition recommendations can reduce weight, but also risk of cardiovascular and cancer mortality. Prescription medications may complicate weight loss for patients. There are effective medications available for long-term weight management. Bariatric surgery should be a consideration for patients who are appropriate candidates. And I will take any questions.
All right, outstanding talk, Dr. Hittepole, and Dr. Kruger, I'll let you lead off here.
Bridget, that was fantastic. It was very great to hear the complexity and all the different things, including all the medications people are on, the microbiota influences, the food deserts, unavailability of food. I guess I think the thing that strikes me, and maybe you too, is that because obesity is continuing to go up, that our major fight, I'm going to say it, is with marketing and marketing for our kids, and fast food and kid food on the menu that is just horrible, and how people just succumb to that because of the pressures in the market. I wonder if you would comment about that, because I think the battle, now everyone talks about the drugs for leptin and ghrelin and stuff like that, and then that's just going to put more money in the pharmaceutical pockets and less in your patients' pockets. So what do we do with the high fructose corn syrup, which really became in everything since 1975, and the marketing? What do you do about that?
I think you bring up a great point, and this is something I've thought about before. I think we almost have to start looking at this like we've looked at tobacco. You know what I mean? Like we started taxing tobacco like years ago and put that money into like a fund to treat like tobacco related illnesses. And I think that's where we need to start shifting the narrative. But what's difficult, you don't have to smoke, but you have to eat. So like, where do we draw the line though? Like, do we start like taxing sugar? Do we start taxing like takeout containers? You know what I mean? Do we start taxing the plastic bottles? I think it's got to be somewhere. Was it Bloomberg in New York that was like tried to ban like large sodas, and people like just were so angry at that. But it has to be somewhere that we are making a decision about health, because, and I don't want to get political here, but like our nutrition guidance has come from like an agricultural organization, like the USDA. It's like, that kind of doesn't make sense. Like that, I mean, that's not really like from like an organization that like talks about, that's kind of promoting like beef production and all this from our farmers, which it's great that we have like these industries, but like, is that really where this needs to go? Like, is that who really needs to like give these nutrition guidelines? Because maybe that's not where this needs to be. So no, I think we need to start looking at where some of this money is. And like, I hate to say this, but even some of these things that I've looked at, a lot of the funding for some of these organizations comes from Coca-Cola, Dannon, some of these companies that are really like, you know, creating some of these problems, I'll say.
May I, I'm a cardiologist. May I please make a comment? Can
Yes.
you hear me? We, atrial fibrillation is much more common in obese people. And there are studies in our literature that if those people lose weight, the management of atrial fibrillation is easier. But as you know, people can't lose weight. So we are freely recommending that they have gastric bypass in obese people who have atrial fibrillation. And those people, it seems to help in those people. Management of atrial fibrillation becomes easier.
I'm sorry, I didn't quite catch all that. Can you say that again?
Atrial fibrillation is common, much more common in obese people, considering other risk factors. So there are publications in the cardiology literature that if those people lose weight, mostly with gastric bypass, management of atrial fibrillation becomes better, easier. Did you hear me?
I got the first part. I didn't catch the last part. I'm sorry. There's people in my hallway who are noisy.
He was saying that they recommend gastric bypass for obesity associated with AFib. Yeah.
Yeah. And I guess if, more people with AFib are older as well. And, that last study showing that people, 55 and older benefiting. And, we tend to not think about bariatric surgery for our older patients, but I think that does show that older people would potentially benefit with this too. So it is still a tool that we need to think about, I think, more.
All right, Dr. Hittepole, we're going to try to squeeze one question in from the chat areas from Dr. Emmons over and he asks, can you comment on the relationship between obesity and fatty liver / metabolic syndrome and how reversible these are once established with weight loss / exercise?
So I think it's actually completely reversible. And, my patient case, and I probably should have put some labs up, but most of her conditions actually did get better, in that her weight has come down. She did kind of backslide a little bit, but I do see this frequently in that people will, their ALT does get better. From a fat itself, like if I do a FibroScan study to see if the fat itself is going away. I haven't done that quite as much, but definitely you will see their A1C gets better, their, ALT does get better. But you see a lot of that is very responsive. And, kind of going back to the bariatric surgery, people have remission of their diabetes after bariatric surgery frequently. So, a lot of these do get better with weight loss and it induces remission for a lot of these diseases.
All right. Thank you, Dr. Hittepole. It's 9 o'clock. I know you've got a patient probably, I think, waiting for you. Anyone, if you had a question, I'm sorry we couldn't quite get to him, but you can contact Dr. Hittepole directly. You can email her. I believe it's Bridget.Hittepole@louisville.edu.
Yes.
So I know there's a couple of questions, Dr. Abhyankar, but again, you can read folks that want to get in touch directly with Dr. Hittepole. It's Bridget.Hittepole@louisville.edu, and I know she'll be happy to provide insight. So thank you so much. Dr. Kruger, you want any parting words here before we?
Well, a couple of the comments were fantastic. So you had a lot of questions in the question and answer session. So I think you stimulated a lot of thought in many of us. And one of them, and I completely agreed, that we need to get your expertise and get McClave and get people in the microbiome, people in maybe engineering that want to do machine learning, And with Kim Williams coming, as you know, your new chair in July, he's a plant-based expert. I think
Super excited about it.
Yeah,
Super excited.
Yeah, I mean, to the point that we might actually be able to do something innovative and actually effective for our patients with weight problems. So it's good to know we've got a group of people very interested in this, and with your experience too, I think this is exciting. We might be able to have an obesity center at UofL for a change.
A clinical, absolutely.
Yeah. Okay, thank you so much, and everybody, thanks for your attention and time. And next week, Jason, we know you have to drop off.
Yeah, we're going to take a week off for spring break, because I know a lot of folks will be out of town and with the kids and having a good time. And we will be back on the 14th, and it'll be pulmonary, and Dr. Hiram Rivas Perez will be doing the presentation. So we really appreciate everybody joining us this morning, and thank Dr. Hittepole. I know she had to run, and thank you, Dr. Kruger, and for battling through the technical issues this morning too. So
no problem. Thank you so much.
All right,
Great
we'll see
talk.
everyone in a couple of weeks.